So welcome back to Houston, Texas. We're doing our non-excisional facelift with an injectable technique. We've done our injectable RF. I showed Accutite, FaceTite, and Morpheus, how to contour and shape the jawline, nasolabial, labiomental fold, and then across the buccal space, upper and lower lid, and brow. Now we're going to use a neuromodulator, and I'm going to be using, in this case, it could be Dysport, Xeomin, or Botox. I'm using Evolus. Zoom in on that if you can, real tight there, Matt. That is Evolus. This is Jeuveau in the US, Nusavia in Canada. It's the same thing. In terms of the currency of the world, the US dollar is often, a currency is pegged to the US dollar. Think of Allergan's Botox as US dollar. Everything is, well, how many international dollars to US dollar? Meaning, I'm going to talk about units. How you dilute it, 1 to 1, 2 to 1, 3 to 1, 4 to 1, doesn't change the number of units, just the degree of dispersion. So if Allergan's Botox is 1 unit, you need, in my opinion, 2 units of Xeomin to get the same effect as 1 unit of Botox, Allergan's Botox. I need 4 units of Dysport to get the same effect, 3.5 to 4, as 1 unit of Botox. But I need 1 unit of Jeuveau or Nusavia to get 1 unit of Botox. It's the closest to 1 to 1 of all the other products. And when you factor in that you need more units with some of the other BTXAs out there, they're all about the same price. So pick the company that serves you the best with the least expensive toxin. They all work about the same. You know, Dysport may be a couple days earlier around the eye. They may last a couple days longer. Xeomin might work better in those that, you know, tend to react to the binding proteins of Allergan's toxin. But at the end of the day, I always have a little Xeomin around, a little Dysport around. And I use principally Evolus. But you could use whatever toxin you want. Just hit the right muscle with the right amount. Now, I'm a concentrationist. I dilute 2 to 1. I don't do 3 or 4. The dispersion's a little farther, and I'm at risk of dispersion by injecting Botox in an inflammatory edematous bed anyway. So that's our neuromodulator. We've drawn back into a 31-gauge B&D needle, and I like 2 cc's of preservative saline in every 100 units. That means this is not 30 units of Evolus or Jeuveau, it's 15 units in a 30-unit insulin Ultralante BDD2 needle. And so this is 30 down to 20 is not 10 units, is 5. 20 down to 10 is 5 units. 10 down to 0 is 5 units. And I use 5-unit aliquots almost everywhere. And so you remember she had a strong central depressor. Let's treat her procerus. 5 to 10 units, right where the horizontal crunch line is. 30 down to 20, 20 down to 10. There's 10 units. Now, as you see, I use my palm and my stabilized index, middle, and thumb to pull in and inject. I pull back with my ring finger. That means no dripping. Now I go up to depressor corrugator supercilii, which is right in the central part of the head of her brow. I grab it. I tend to rotate in so it doesn't cause a lot of trauma, but she's numb. She doesn't feel any pain. But in your technique, there's 5 units. Pull back. In your technique, when the patient doesn't have anesthesia, everything matters. So rotate in versus burst. Rotate in, and then I inject with my palm. My index middle, my index, middle, and thumb stabilize the base of the syringe, and I inject 5 more units. There's 10 intercorrugator supercilii. When she's this swollen, I don't go after the tail of her corrugator because it can be dispersion over the orbital rim onto her levator aponeurosis, causing ptosis. So I treat procerus, depressor corrugator cilii. I might do 5 units into her body of her corrugator, but I do not treat the tail. Too much risk of a dispersion. Now, how much dispersion when you have 1 to 2 to 1 dilution? About 1 centimeter. At 3 or 4 cc's per 100 units, you're going to have 2.5 centimeters, which is way riskier to go onto muscles you don't want to hit. That's why most are concentrationists, which are 1 to 2 cc dilution. Okay, that's the central depressor. Lateral depressor, when she was smiling, she was doing this, the upper orbicularis oculi, middle, and inferior. Don't get dispersion over the orbital rim, or you might hit lateral rectus and get a diplopia. Do not get dispersion over the orbital rim. You might get levator aponeurosis and a ptotic lid. This biggest risk here is a bruise, so I stay intradermal, like you're doing a TB injection. 5 units in the upper orbicularis oculi, 5 units, 30 down to 20, right at the lateral canthus, 1 finger breadth away. And then come around the corner and be very careful here. She's very swollen from all my Morpheus. And there's going to be a lot more dispersion, more than 1 cm, maybe 2 cms. And you get onto zygomatics major very quickly, and then she can't smile symmetrically. So be very cautious on this inferior one. Even don't do it sometimes. And bring her back. So 5 units here. Now, compensatory recruitment of her nasalis. She's going to try and frown through her nasalis halfway up the nasal sidewall. Watch out for the angular vein, about 2 units. And in the mid-pupillary line, she's going to recruit horizontal orbicularis oculi, so about 2 units in her mid-pupillary line. Do not inject the infraorbital orbicularis oculi if they've had a previous blepharoplasty, they have lower lid laxity, they complain of dry eye syndrome, or they have orbital fat pads. They need their orbicularis oculi. Do not weaken it in those 4 circumstances.